And then I'll say, welcome everyone. My name is Karen Brownlee, and I am the Adult Program Coordinator with the North Suburban YMCA in Northbrook, Illinois. And in that role, I offer a variety of adult programs, including the Adult Education Series, which you are attending today. And in the Adult Education Series, I've been doing that for about three and a half years now through our Y. And what that entails is I bring in experts in their field, like Rosemary, to talk about their areas of expertise. And though these programs always have a focus of adult education in mind. And that can range anywhere from 18. I had a speaker on earlier or in September who talked about writing the perfect college essay, all the way through the end of life. I'm actually going to ask someone to come and speak about planning funerals as well. So from the full range of adulthood. But I have speakers like Rosemary to talk about all types of things. We talk about health, we talk about fitness, we talk about money management, we talk about entertainment, we talk about elder law. I have an elder law attorney who speaks every month. So if you're interested in learning more about this programming, you can, in the chat box, share with me your email address, and I will send you an email giving you some more information. And for those of you who are professionals in the field, if you would be interested in offering a presentation through the North Suburban YMCA Adult Education Series, I am now inviting people from all over the country to join us. And we are hoping there is not another Y that does this type of programming. And my ultimate goal for this programming would be to share it with other Ys. And now that everybody's virtual, we can do that. We can have Ys from all over the country share with their populations the things that we're doing, and it don't cost nothing. It doesn't cost them anything to invite people to join a Zoom call. So I'm hoping that over time we can sort of bridge an educational gap that's out there. You know, the hardest part for seniors in our community is figuring out how to do this, how to do a Zoom call, because not everybody knows how to do it. So if anyone can think of how to teach someone how to do this without having to use technology to do it and without having to go into their home, I'll hire you. We'll figure out a way to help people be able to tune in when it's really, when it's really almost impossible for some people because they don't know what a URL is, they don't know what a browser is, and it's really challenging.
Karen,
in addition to the Adult Education Series, I'll just give you a little quick bit more about what we do adult programming wise at the Y. We play brain games 3 times a week. We have a social networking group. We have a social club. We used to get together for dinner and lunch once a month, and we would go out and have about 15 people show up to dinner or lunch. Now we're doing it all virtually. So people just get together and we eat together on Zoom. And it's working. It's not quite as much fun, but the brain games are great. We challenge people's brains. We play all different kinds of online games now. So if you know of anyone who's looking for some community, especially during the pandemic, it's an easy way to commune with other people. And then I also teach some classes for seniors. As I was telling Rosemary earlier, I teach a class this morning at 8 o'clock. I teach a class that's called Improve Your Balance. I teach classes called Balance for Walking and Core and Functional Strength. And these are all geared towards seniors. I've got some people who are in their 50s in my classes, but those people have what I call special bodily challenges, knee replacements, hip replacements, fibromyalgia, something along those lines where they're challenged. And that's my area of expertise. I've been a personal trainer for 29 years. So I've been doing this for a really long time, and I love what I do. So thank you all for joining us today. Rosemary Gerster is from Senior Helpers, and we've been actually working with Seniors Helpers, I think even before you were there, Rosemary. And they've been doing programs for us for a number of years, and they always have very professional programs. She's going to provide a lot of education today. This program obviously is about learning more about Parkinson's disease. So again, thank you all for coming. Thank you, Rosemary, for lending this information today. Thank you to those who sent me chats, and I will look forward to reading them and getting in touch with you and building our relationships across the board. So thanks, everybody. I am going to mute myself. Rosemary, do you want people to mute themselves during the presentation or leave themselves live and then ask questions at the end?
Whichever they want to do, it's people who are in quiet places can stay unmuted, whatever you want to do.
Great.
I'll tell you to mute if I need you to. Okay.
Terrific. Thanks, Rosemary.
Let me go ahead. Thank you, Karen. Let me go ahead and start sharing my screen here. Okay, let's get going. Okay, so as Karen said, today I'm going to be talking about Parkinson's disease, and it looks like for the most part, I'm speaking to fellow professionals. This program was designed to be, it's a sort of part, this is kind of what our CEU Parkinson's program is like. I modified it a little bit in anticipation of also a senior audience. But it's hard to make Parkinson's Parkinson's presentation sexy, shall we say. So it can be a little bit, some parts can be a little bit dry, but I try to at least make it more palatable than the normal CEU. As most of you on this call know, but some of you may not, I'm from Senior Helpers. Senior Helpers, we do in-home care for seniors. Our services range from companion to personal care to end-of-life care. Our coverage areas are pretty extensive. It's about Northbrook to the border. We wrap around for Des Plaines, Arlington Heights, Schaumburg, and then DuPage County as well. DuPage pretty much up to Naperville. This Parkinson's presentation was created in conjunction with a nurse named Becky Dunlap. She works with Johns Hopkins in their Parkinson's Center. She also works for the Parkinson's Foundation. She is who Senior Helpers brought in to help us create a training program for our staff, our office staff, for our caregivers, and then also for a program for the community. I am by no means an expert, but Becky Dunlap is for sure an expert. Today, I think there are 3 objectives. Express a basic comprehension of the symptoms, including motor and non-motor. I'll be harping on this a few times in the presentation. There's the underlying idea here that the motor symptoms of Parkinson's can be very well managed because that is where the research has been in the past. The research has mostly been towards finding medications and treatments to treat the motor symptoms. There is not that body of research for the non-motor symptoms. And we do not have as good of methods for treatments or therapies for treating the non-motor symptoms. And those symptoms, the non-motor symptoms, tend to be the ones that affect quality of life the most. So, the industry is a little bit in a predicament there at this moment. We'll talk about the best treatment and management for, again, most of the treatments and management are currently for the motor symptoms. And I'll talk about a patient-centered management plan, which is regarded as sort of the team approach to helping those with Parkinson's disease. So what is Parkinson's disease? As we go through it, we can think about the 4 M's. The first M is Parkinson's is misunderstood. Everybody thinks that they know what Parkinson's is and they identify it with 1 or 2 symptoms. But there's this whole constellation of symptoms which people don't know are associated with Parkinson's and therefore don't recognize as being a Parkinson's symptom. For example, the masked face, that expressionless face. Without any further information, someone might encounter somebody with the masked face and think that they were depressed or angry or, had some sort of dementia. They misunderstand sort of what is and isn't part of Parkinson's. Parkinson's is misdiagnosed. Even though it is the 2nd most common neurodegenerative disease after Alzheimer's disease, there are individuals that go for years without being diagnosed, or they're diagnosed as having Parkinson's disease when in fact they have a Parkinsonism or an atypical Parkinson's disease, which we'll talk about later. We'll talk about today how true idiopathic Parkinson's is diagnosed. Parkinson's is mistreated. 3 out of every 4 individuals with Parkinson's do not receive their medications on time, especially when they're in the hospital. Today, we'll talk about the vital role that timely administration of medication plays in the management of the disease. And finally, Parkinson's is mismanaged. Again, this can be an issue of hospitalization. If someone's coming out of the hospital, they're going into rehab, they likely have difficulty walking, and in most situations, we find people in rehab, they're put in wheelchairs for longer than they should be to keep them safe at the rehab, but it's one thing to do this with someone who's coming off a hip replacement. It's a different thing to do it with someone with Parkinson's, for whom exercise and movement is it occupies a higher tier of importance in terms of the management and treatment of their symptoms. But we find this across the board. Parkinson's is often mismanaged. Idiopathic Parkinson's. So idiopathic means that we don't know the cause. We still don't know the cause of Parkinson's disease. Idiopathic Parkinson's is a chronic, complex, and progressive neurodegenerative disorder. Parkinson's is chronic. There is no cure. They're unlike acute diseases like pneumonia. We don't have a cure. It's not going to go away. It's more like asthma or diabetes at this point. That said, people can and do live full lives with Parkinson's. Think about Michael J. Fox, who's arguably the most famous person who has Parkinson's disease. Parkinson's is complex. There's an array of symptoms and presentations, and they all differ from patient to patient. Speaking of famous people with Parkinson's disease, think of some other famous people with Parkinson's disease. Janet Reno, Muhammad Ali, Robin Williams, and Pope John Paul II. All of these people had Parkinson's disease. All of these people manifested the symptoms in a different way, at least in the public eye. Finally, Parkinson's is progressive. It will worsen over the course of time. We have great medications to treat the symptoms, but we have no medications to slow the progression of the disease. Parkinson's is the second most common neurodegenerative illness after Alzheimer's disease. This is really a key take-home message. With the growing aging population in this country and around the world, there are going to be more and more individuals living with Parkinson's disease. We must offer training to those that have the disease and to those who are taking care of those with Parkinson's disease. And this is sort of what, really motivated me to sort of get this presentation and things like that out. It's our own hands-on experience with our clients who have Parkinson's disease and their families who just don't have enough information. They've known they've had the diagnosis for a long time, but it wasn't severe enough, or it just wasn't top of mind. And it really needs to be. Parkinson's is the kind of disease where you're going to create a life around it, most likely, in order to be able to live your best life with it. As we talk about the disease today, I want you to think of the word move. M stands for the movement symptoms of Parkinson's disease. Parkinson's is most often thought of as a movement disease, although, as we will discuss, it is not singularly a movement disease. O stands for the other non-motor symptoms of Parkinson's. And when we talk about the other symptoms of Parkinson's, there's both other non-motor and then there's other motor that don't fall under those cardinal motor symptoms that we will discuss. V means that Parkinson's varies from one individual to the next. There's a saying that if you've seen one person with Parkinson's disease, you have seen one person with Parkinson's disease. I've seen a lot of Parkinson's disease and it is never the same, and I never stop being surprised and, to see new symptoms that I knew, I knew that this kind of symptom exists in theory, but, we see new things with it all the time, the more interaction you have with the disease. Finally, E represents the evolution or the gradual worsening of Parkinson's. As we said, Parkinson's is progressive. It's going to worsen over time. So the number of individuals living with Parkinson's is projected to increase as individuals live longer. It's difficult to know how many people in the US have Parkinson's disease because slowing down is both a symptom of Parkinson's disease and also just considered part of the normal course of aging. So we think that it's probably underdiagnosed. Parkinson's is, experts think that there's about 1 million people in the United States living with Parkinson's disease and 4 to 6 million worldwide. Parkinson's does not discriminate with respect to race or socioeconomic status. It does seem to have a slightly higher incidence in males. And by 2030, the number of people with the Parkinson's diagnosis is expected to double. Age of diagnosis is one of the variable factors that often leads to misdiagnosis, particularly in those who have young onset Parkinson's disease. It is largely a disease of midlife, although 5 to 15% of those receive a diagnosis under the age of 50. And as individuals age, the number of individuals with Parkinson's disease increases to about 1 out of every 100 Americans over the age of 60. During the next few slides, we're going to review the motor or movement symptoms of Parkinson's disease, and there's been a lot of focus on those symptoms since Dr. James Parkinson, the namesake, initially described those symptoms in 1817. Research for the disease, research for improved medications has focused on the reduction of the movement symptoms. I mentioned this before. So today we have great medications to control the movement symptoms of Parkinson's disease. That said, now we know that the non-motor symptoms are the symptoms that affect quality of life even more than the movement symptoms, and the research for the non-motor symptoms just isn't where the other research is quite yet. So there are 4 main motor symptoms of Parkinson's disease. These are called the cardinal symptoms, and they are tremor, rigidity, bradykinesia, and postural instability. When an individual has at least 2 of the top 3 symptoms, the physician will consider a diagnosis of Parkinson's in the absence of any other reason for those symptoms. Again, it's 2 of those top 3. So tremor, rigidity, bradykinesia, 2 of those 3. In the absence of any other reason for those symptoms, the physician will consider the diagnosis of Parkinson's disease. A key take-home message here is that a person can have Parkinson's disease and not have tremors. It's not, Parkinson's isn't just a disease about tremors. It's not just a disease about freezing. It's multifaceted. Someone can have Parkinson's and not even have tremors. Postural instability, that 4th cardinal symptom, if it occurs, it usually occurs late in the disease. If it happens earlier in the disease and a person's Parkinson's symptoms are otherwise properly medicated and they're still experiencing postural instability, it's most likely that they actually have an atypical Parkinsonism and not true Parkinson's disease. Because again, for true Parkinson's, this postural instability, this is going to be a late stage affect. Talk about tremor. The tremor of Parkinson's is a resting tremor, meaning that it occurs during rest. The other kinds of tremors that exist are action and postural, but that's not the one we're talking about here. An action tremor occurs when somebody's engaged in an action like drinking a cup of water. That would be the thing that triggered the tremor. A postural tremor occurs when someone is holding their arms in a certain position. That would be the thing that triggers the tremor. That's not this tremor. This is a resting tremor. The tremor begins unilaterally, meaning on one side of the body, and then generally progresses to the other side of the body. In the next video, we have an example of a tremor. See if this gentleman has a tremor on the right side of his body. He's at rest. You can see that it's becoming slightly bilateral, and you can see with his feet, it's also in his foot, and you can see on his left foot, it's starting a little bit there. The second cardinal symptom is rigidity. The rigidity of Parkinson's is known as a cogwheel rigidity, since the physician feels a ratchet-like feeling in the joints. This also starts unilaterally and will progress to the other side of the body as the disease progresses. From the perspective of the individual who has Parkinson's, it feels like stiffness in the joints. So it can be difficult to distinguish between what is rigidity and what might be arthritis, which is another thing that again can complicate diagnosis. In the next video, we'll show an example of rigidity. The third cardinal symptom is called bradykinesia. Bradykinesia, or slow movement, again, starts unilaterally on one side of the body and gradually progresses over time. Brady means slow and kinesia means movement, so you put those two together and slow movement. The best way to describe it is think of life in slow motion. Think of all the things that you do every day that you don't even have to think about, and then think about if you had to think through each of those tasks. That is, patients with Parkinson's complain that getting dressed, washing their hair, preparing meals, all those things, they become arduous tasks due to bradykinesia. Over the course of many years, or as the disease progresses, it may reach a point where there is no movement, especially first thing in the morning, and especially before the medication has been taken. This is why in most people with advanced Parkinson's, but no matter what stage you are with Parkinson's, medication has to be taken at the right time of the day, at whatever junctures of the day as prescribed by the physician. In the next video, we're going to take a look at bradykinesia, and some other symptoms actually are on display here. So you can see that lack of arm swing is one of the can be one of the symptoms there of bradykinesia. The gentleman here is also had a moment of freezing there. And he's also slightly stooped. What you can't see is that this gentleman with bradykinesia is thinking his way through what he's doing. He's thinking his way through the walking. He has to think his way through those turns. The fourth, postural instability or impaired balance. Like I mentioned, the balance problems of Parkinson's disease usually occur late in the disease, and they're often best addressed with physical therapy. Individuals can develop a stooped posture over time, which throws off their center of gravity. Obviously, they are at higher risk for fall because of that and for multiple other reasons as well. There can be a complete loss of or a near complete loss of automatic movements. Again, most of us move without a thought. In Parkinson's disease, they'll have to start thinking through swinging their arms, picking up their feet instead of shuffling, which can also be something that starts to appear with Parkinson's a little bit later in the disease, or freezing and those other things you hear about. Those are generally things that happen later in the disease. This is here, in this video, we'll see some impaired balance, but we'll also see what's called fascination, which is when someone with Parkinson's takes very quick steps and has to then think to stop themselves. You can see that he too has to sort of think his way through these movements to get himself going. And he has tremors as well. So the Hoehn-Yahr staging, this is something that was used, it was published in 1967, and this is what was commonly, and it still is used to stage Parkinson's disease. But this was mostly used before we had the kind of medications that we have now. And what was, you can see in this, you can see sort of the progression of the symptoms from no signs to both sides of the body and the cessation of movement. Now, most individuals today live between stages 2 and 3 for many, many years. It's rare, given the excellent medications that we have for movement, that somebody with true idiopathic Parkinson's disease will end up in stage 5. Those who do reach stage 5, it's generally not Parkinson's disease. Usually it's an atypical Parkinsonism, like, and again, we'll talk about some of those later. So now we're going to talk about the non-motor symptoms of Parkinson's disease, which are, I said, it was a vast constellation, but we'll sort of do our best to hit on a few of them. So what is non-motor symptoms? According to the National Parkinson's Foundation, the non-motor symptoms of Parkinson's disease are defined as those symptoms that do not affect movement, coordination, and mobility. Again, the research that does exist demonstrates that these are the symptoms that most impact quality of life, much more so than the movement symptoms. According to the National Parkinson's Foundation, the impact of depression on quality of life, depression being one of the non-motor symptoms, is almost twice of that of the motor impairments universally associated with Parkinson's disease. And again, these will vary greatly from person to person. The non-motor symptoms can be broadly divided into psychiatric mood disorders, psychiatric cognitive disorders, dysautonomia, which I will mispronounce that word multiple times throughout this presentation, sleep disturbances, other motor symptoms, and then other symptoms. These symptoms present at different times during the progression of Parkinson's disease. Thankfully, the Michael J. Fox Foundation is studying the presence of the non-motor symptoms before they do research on the motor symptoms. And that is the sort of focus of their research. Thankfully, they're the ones who really got it, got the ball rolling with getting the research for treating and medications for the non-motor symptoms. A complete discussion of the non-motor symptoms is obviously beyond the scope of this presentation. You can see some of them here, but it's important, especially for healthcare providers, to have an idea of what these might be, so that you can recognize the existence, the potential that if somebody with Parkinson's is experiencing those, it may be something due to Parkinson's, or it may be this in light of some other things that are going on to them may trigger sort of investigation of, is this person suffering from Parkinson's or what's going on? We're going to highlight a few of these in the next few slides. So again, I mentioned the other non-motor symptoms can be broken down into other motor symptoms, just because there are other motor symptoms that aren't the cardinal motor symptoms. So some of these other motor symptoms you have listed here. The big ones that we see are difficulty swallowing, drooling, and decreased blinking. I would say that those are more common, that at least in my experience, than the others. But they become very interrelated. So, for example, someone might have difficulty swallowing, and that might result in drooling. Someone with excessive drooling, perhaps the doctor will, do neurotoxin injections in their salivary glands to help with that. But then that can put the person at risk for aspiration, which is another serious issue with Parkinson's disease. And that can put the person at risk for pneumonia. So, these sort of single treatments in of themselves are never enough with Parkinson's. In that kind of situation, you need to bring in a speech therapist to assess really sort of what's going on. Those kind of specialists will also be the one who can address voice volume, which is something that we see somewhat frequently, as well as issues with pronunciation, which is called dysarthria. We talked about the masks, like the expressionless face. There's no treatment for that, but that's something that could be extremely embarrassing to somebody. So it's incumbent upon their team and the people surrounding them to, help them, not make assumptions about how they're feeling. You need new ways of interacting with them to draw out, how they are feeling about a situation, and to know when something is truly bothering them versus when they just have the masked face. Another interesting symptoms are the altered taste and loss of smell. That can significantly impact appetite and cause weight loss. What's the treatment for that? Well, you might need to have more seasoning of food. You can see how one of these symptoms, the quality of life impact of these non-motor symptoms can be, again, much bigger than the impact of the motor symptoms. The autonomic nervous system manages bodily functions like digestion, hormones, temperature control, heart rate, blood pressure, etc. There can be disruption with this system due to Parkinson's disease. In this sort of category of symptoms, the big ones that we see and the big ones that deserve mention are constipation, as well as the low blood pressure with positional changes, which causes orthostatic hypotension. Constipation can usually be managed in people with Parkinson's disease. It can be managed with diet, with medications. In the worst case scenario, Parkinson's patients might struggle with gastric paresis. and need more aggressive management to avoid a ruptured bowel, avoid a ruptured colon or bowel. If someone is experiencing frequent orthostatic hypotension, that can usually be managed by discontinuing. It's almost like inevitable. It's that the person with Parkinson's disease also has high blood pressure. So all the time, they are on both high blood pressure medication in addition to the Parkinson's medications, fine. But then when orthostatic hypotension becomes an issue, perhaps they need to have those medications altered in some way or another. And also, they might need some liberalization of salt in the diet, which is also thought to be something that will happen with orthostatic hypotension. But again, it's a team approach. You can see there are multiple medical professionals and care professionals that need to be communicating here to help this person live the best quality of life that they possibly can. The majority of those living with Parkinson's disease will experience some kind of psychiatric, one of the psychiatric disorders or more than one of the psychiatric disorders at some point during the illness. 50 to 70% of those living with Parkinson's disease experience depression. 30 to 40% experience anxiety. These are treatable problems with medication, with therapy, with counseling, but these are real issues that, again, these are the things that we really think of when we're talking about what's affecting their quality of life. The impulse control disorders and psychosis are often side effects of medications, which are usually treated with additional medications or adjusting their current medication regime. The cognitive issues may occur early or late in the disease. Very commonly, individuals experience what's called executive dysfunction, which is problems with planning, problem solving, reasoning, and abstract thinking. Dementia is something that will vary in Parkinson's disease. Some will never experience any issues with dementia. The studies vary in what the incidence is thought to occur in 30 to 70% of those with Parkinson's disease. Many individuals experience bradykinesia, which is slowness of thinking. And these individuals should always be aided by their team, encouraged to take their time, and made to feel okay about having to think their way through tags or think their way through being able to say something. How is Parkinson's diagnosed? All the national organizations agree that an individual who suspects they have Parkinson's disease should be seen by a movement disorder neurologist at some point during the disease. Studies have shown that these are the most accurate at diagnosing the disease. Movement neurologists have had additional training in this area of neurology. Typically, they will complete a thorough physical and neurological exam. There is no blood test, there is no MRI, there is no X-ray to diagnose Parkinson's disease. There is a DAT scan, but that's not usually used by movement neurologists because they know what they're doing. They know how, they don't need that to be able to properly diagnose the disease. Parkinson's disease versus Parkinsonism. So it's important to make a distinction between what is Parkinson's disease and what is Parkinsonism. Parkinsonism simply means that a person has features of Parkinson's disease, but that they probably do not have idiopathic Parkinson's. They have symptoms that are or mimic those symptoms of Parkinson's disease, but they don't have Parkinson's disease. This can happen. Some individuals exhibit this for medication use. So certain medications can cause tremors in themselves. Reglan is an example of a medication that we see which treats GERD that we've seen that causes some symptoms. Others might not have Parkinson's disease, but they might have what are called atypical Parkinsonisms, like progressive supranuclear palsy, cortical basal syndrome, or Parkinson's with Lewy bodies. So these are, again, these are not Parkinson's disease, and they're honestly not even researched that much themselves, and they're not given a whole lot of they're not given a whole lot of respect in their own space. We have clients come to us. We've had clients with progressive supranuclear palsy, and their best is when they call, they say, "Well, my wife has a disease. It's kind of like Parkinson's. It's its own thing, and it's similar to Parkinson's, but it's not Parkinson's disease." But Parkinson's disease, again, is the more common of the diseases, so it's the one that, you know, gets more money in the research, gets more attention. How does Parkinson's progress? It's slowly progressive. By the time the person receives a diagnosis, 50 to 70% of the dopamine cells in the person have depleted on one side of the brain. There are 3 phases of dopamine cell loss. There's the pre-symptomatic phase, during which dopamine cells are slowly dying. There's the pre-motor phase, during which there may be the presence of non-motor symptoms as well, such as sleep disturbance, olfactory problems, mood disorders, and then there's diagnosis. Again, you can't even get diagnosed until you have 3 of those, you know, 2 of those top 3 cardinal motor symptoms. Let's talk about the role of dopamine. Dopamine is the main chemical messenger or neurotransmitter. It's in Parkinson's disease, it's depleted in the brains. Simply put, there are not enough messengers to get the messages out to where they need to go. I think about our postal system right now. You know, there's just, and just the logistics in this country in general, there just aren't enough mail carriers to get the mail where it needs to go on time. That entire process is delayed. That's very much what's happening with Parkinson's disease. You can see here at the point of diagnosis, 50 to 70% of the dopamine producing cells are depleted in the substantia nigra. These cells communicate with other cells in the area known as the basal ganglia, and that's indicated by the arrows. When we're born, we have about 250,000 dopamine neurons on the right and left sides of the brain within the substantia nigra. The triangles, those little triangles there, those show the dopamine being released into the space between the nerve cells and taken up by the receptor cells. And this is the process called neurotransmission. Again, these dopamine, they are the messengers. And in Parkinson's disease, there are not enough messengers. There are not enough messengers to communicate between the brain and the body to get those messages there. So everything is slowed down. And obviously, other things are not working as they should be as well. How is Parkinson's disease treated? Parkinson's is primarily treated with medications. The gold standard medication is known as Untitled. It's a therapy of carbidopa and levodopa. The levodopa, once in the brain, is converted into dopamine. So we're bringing more messengers into the brain, so we're able to better transmit those messages, and that leads to improved movement symptoms. Again, movement. This helps with our movement symptoms. When the disease progresses, there are some surgical therapeutics that may be used to assist the person with Parkinson's disease. There are 2 main ones, deep brain stimulation therapy and Duopa Therapy. The treatment of Parkinson's really requires an allied team of physical, occupational, and speech therapists that are familiar with this disorder, in addition to the other members of the team that we'll talk about later. In addition to that, a healthy, balanced diet and weight management is important in Parkinson's disease. Social support to the patient themselves, as well as their spouse, is very important. And exercise is an enormous component in the treatment of Parkinson's disease. These are some of the medications that are used to treat Parkinson's disease in the United States, at least. There are more in the pipeline, thankfully. So the medication management of Parkinson's is complicated by the motor fluctuations, which will be experienced by about 50% of those with Parkinson's 5 or more years after the diagnosis. So here what we're talking about is on and offs. An on period is a period of relatively good mobility when the medication is effective. An off period is a period of poor mobility when the medication has worn off and the symptoms of Parkinson's return. It can be as drastic as turning a light switch on and off. Some people with their movement symptoms, they'll start to experience dyskinesia, which is a period of like excessive squirminess, excessive movement. Some will experience what's called dystonia. That's sustained muscular contraction. Most individuals learn to regulate their medications in order to achieve the best on time daily. this has been the central focus of patients with their neurologist. Everything is about medication, medication adjustment, and medication timing, which is great. Again, it's very effective in helping to control the motor symptoms. But as the illness advances, that patient might not be able to communicate what their best on times are. That, you know, the executive dysfunction comes into play. That's where they need the spouse or a trained caregiver or some other member of the team to be there to communicate to the neurologist what's happening with the disease. What are the on times? What are the off times? I mean, at a certain point in the disease, someone might need to be taking medications 9 times a day to control the motor symptoms. That's not uncommon. Talk about the third, surgical therapies. I mentioned there are 2 main surgical therapies. So the first is deep brain stimulation surgery. This is the older of the 2. It's a reversible procedure in which an electrode is implanted into the brain to control the abnormal electrical impulses. So think of it kind of as a pacemaker for the brain. In the right person, it's very effective, but it's not necessarily appropriate for everybody with Parkinson's. The second is Duopa Therapy, and Duopa Therapy, it was approved in 2015, but it's still relatively new. I actually had to reach out to Maureen recently to talk about Duopa Therapy. We're only really starting to see it with our patients with Parkinson's. What Duopa Therapy is it's a pump delivery system of the carbidopa levodopa, so that sort of that, you know, gold standard medication. When that medication taken orally is no longer effective in controlling those on and off times, Duopa Therapy is an option. Duopa Therapy will deliver the medication through a pump to the small intestine through a tube, basically a tube that's attached to a packet of medication. It's a gel delivery through the tube, through the stoma to the small intestine. It is very, very effective. I mean, the medication reaches your body like that. It can be, obviously, this is for an advanced situation because this is an advanced therapy. But it's very promising in helping those who previously, once the oral medications no longer worked, there were no other options for them. These are, again, are not cures. These are therapeutics that helps physicians be able to control the symptoms of those with advanced Parkinson's. Importantly, exercise is as important as medication in Parkinson's disease. And that's a strong statement, but it's true. Exercise is really, really important for controlling the motor, to improving the motor function of those with Parkinson's disease. And the research bears this out. Every person with Parkinson's disease should be exercising, whether it's dance, walking, Tai Chi, yoga, whatever, weightlifting. Rock Steady obviously is a class and a program that was created around Parkinson's disease. Really important that whatever the exercise is, it's something the person enjoys doing so that they'll do it. It doesn't matter if, you know, if they don't like it, they're not going to do it. And someone with Parkinson's needs to exercise every single day. Exercise will lead to better posture, better strength, improved balance, improved walking ability, and just across the board, all of that leads to fall prevention, which obviously we in the industry are constantly trying to do. Fall prevention is an enormous issue with seniors. You know, the overarching, you know, message here is that we need a team. I'll go ahead and read this part. Individualized therapy involves not only the pharmacological and surgical management, but also the appropriate use of allied health professionals, assistive technologies, educational and support resources along the chronic illness continuum. This statement emphasizes the importance of a team and the importance of creating a plan that's unique to the circumstances of each person with Parkinson's disease. Parkinson's disease is not, no plan is one size fits all for Parkinson's disease. Again, you've seen one person with Parkinson's disease, you've seen one person. Every treatment plan is going to look different. So this is an example here of what we're talking about. We're talking about patient-centered care. You know, this obviously this is a big team, but this is, if you look and you know sort of think about the role of each person on the team, it's not overkill by any means. I mean, you know, we can see each of these roles having a very important part of helping a patient with Parkinson's manage the disease, particularly as it advances. That said, all of these allied health professionals are not necessarily appropriate for every person with Parkinson's. Every plan should be individualized. So here's what maybe an individualized plan looks like. For activities might include dancing, yoga, or chorus participation. It's of course very important that a person with Parkinson's disease continues to live their lives and continues to do the things that they've always enjoyed doing. Another thing is maybe a medication timer, which will help someone who's living, particularly maybe mostly independently, will make sure that they're getting those reminders to take their medication at the same time every day. The Aware and Care program from the National Parkinson's Foundation is a hospital-ready program. It helps individuals with Parkinson's disease be ready to go to the hospital, because that, I mentioned earlier in the presentation, is where a lot begins to fall apart. And especially with respect to medication timing, with respect to exercise, et cetera. And Parkinson's, people with Parkinson's are hospitalized 50% more than individuals without Parkinson's disease. Quarterly visits to their neurologist, as well as periodic visits with their neurologist nurse, or telephone calls, check-in telephone calls. A service dog might be something that would be implied. Service dogs are known to help with freezing of gait. So when that becomes a symptom that's causing a lot of disruption to everyday life, service dog might be a great thing. A trained caregiver, obviously, whether that's the spouse, whether that's a neighbor, whether that's a hired caregiver from a company like myself or Dan's, that would be someone who could be sort of that, a conduit for communication about, what's happening, where are the on times, where are the off times, so that everybody, again, is on the same page about what's happening, how the disease is progressing, because it will progress. It does progress. You can't stop that. And of course, family. Family is central to helping a person with Parkinson's, and education for the family is especially important. And that's something that we find lacking, at no fault of the families by any means, but it's something that sort of we as a community can hope to provide for the family. And that helps to, again, that's the most probably important foundational element of caring for someone with Parkinson's disease. I want to mention two resources. Obviously, I want to mention Senior Helpers of Greater Chicago as a resource. We have Parkinson's trained caregivers. We know a lot about Parkinson's disease, and we are happy to answer any questions about the disease, refer you, point you in the right direction. The other resource I want to mention is the National Parkinson's Foundation. That phone number up there, it's not the people who answer the phone, and they answer it 24 hours a day, 365 days a year. You could have an issue, it could be a spouse, and the husband, for example, all of a sudden is freezing, and maybe the medication isn't addressing these off times on a holiday are becoming so severe, and he's freezing in a way that he hasn't, froze before, and the techniques to unfreeze aren't working anymore. You can call the Parkinson's Foundation, and an RN calls you back and will talk you through a process. I mean, they're really it's an on-demand nurse to help you with any sort of problem that you, a patient, a client, a loved one might be having. When I had this issue when I was sort of working with a patient with Duopa Therapy recently, the Parkinson's Foundation was an excellent resource. So I always like to pitch them as well. And with that, I will take questions if anybody has any.
I don't have a question, but a comment about the exercise. Leslie Stahl from 60 Minutes, her husband has Parkinson's. She did a nice piece on it a while back. But interestingly enough, for the exercise, she had him in boxing classes.
Boxing is very, I've seen very popular. Again, the Rock Steady got created. It's primarily, I think, a boxing class. That seems to sort of, they talk about the big movements are the ones that really help with Parkinson's disease. And I think boxing, it can catch those big movements, and it's also fun. That's a big one. Like, who doesn't want to
Get some aggression out.
Yeah, exactly. Exactly.
I have sort of a maybe an unusual question. Is there a type of person? I have heard that there might be a personality type of person, a very intense person, are the kind of people who end up with Parkinson's disease. Is there any truth to that?
I don't know if that's bared out by any, research. When we've seen it happen with all kinds of people in all walks of life. I think that, is it because of using the brain in a certain way for duration of time, for like the length of a career, does that make one more inclined to develop it or not? I don't know. I'm sure, it's being researched, but it's one of those question marks still.
Thank you.
But it happens. I think one of the reasons people might think that is because it does happen more commonly in males. So if you are thinking about men as being, having certain characteristics like that, being more intense, or, having jobs that, for decades that require a certain set of skills in a high, more commonly than women, maybe. But really all that we do know is that it happens more in men. That's the only sort of disease preference that is proven.
Well, I think the other causation is brain trauma, though, also from look at Muhammad Ali, who was a boxer, long-term. And I have a friend actually who is female, and she had been with her first husband and had, physical abuse. So we could probably pin it back to that for her, potentially.
Right.
But I have a current client now who was just recently diagnosed with it, so it hasn't progressed too far. And he has been a business owner, and he just sold his business. So, potentially he had that personality.
Right.
Is brain trauma something that you've seen in the research too, or is that a little bit more anecdotal as well?
I don't know if it's, I honestly, I'd have to look. I didn't come across it in, my research, but Maureen is there. There's more research now, and this is with dementia too, about trauma, brain trauma, as is increasing the risk of developing things like Alzheimer's or the associated dementias, any number of them.
Right. And the place in the brain is very close with Parkinson's and dementia.
Right.
And unfortunately, quite a few people with Parkinson's do end up with dementia.
Yes.
Later, not
right.
Early on.
Right.
Thank you.
Does family history play a role in any way? Genetic predisposition?
Not to my knowledge. Does anybody know, Maureen? Do you know?
I don't know for sure. It just seems like for the most part, most anything, there is that possibility, and it just depends on lifestyle again and stressors and whatnot as to what's on your DNA that's going to come out and be there. And maybe not everybody in the family will get it because, again, everybody responds to stress and life stressors and all that differently.
And also a big thing is that just people are living longer. There's just we're looking at a longer timeline now than we were with those we would refer to for family history. So, so that can affect the research as well. If you're studying a 95-year-old and their mother and father and their mother's mother and mother and father's mother all died when they were 70. You know, that's decades that you're missing as far as family history goes.
Right. No, that's true.
All right. Well, thank you, everyone. This has been a, you know, I like it when there's conversation as well. I think that it really helps when there's a discussion about something. So thank you all for your involvement. Rosemary, wow, that was a lot of great information. So thank you for sharing.
Oh, sorry.
Yeah.
And it was very understandable, Rosemary.
Thank you. I
Yes.
appreciate that. I appreciate hearing that.
Yeah, and I like the way your slides also, you had one that sort of had the conglomeration and then you broke it down. These are these symptoms, these are these symptoms. That's really helpful to help everybody understand sort of what's coming and what's going.
Absolutely.
So thank you. Really, the whole thing was wonderful. We will be posting this. So if you know of anyone who you think, wow, they really should have attended this, we are recording this program and it will be posted on the North Suburban YMCA's website as a podcast under the Adult Education Series. So the WISE website is www.nsymca.org. I get it from the cloud. I send it to our marketing team. They put it up on the website. So it'll probably take a day or two for it to get up there. But a bunch of our programs are on there. So you can also see some of the other programs that we've hosted. So, if you're interested or if you want to send people to find this, it will be on the WISE website. And Rosemary, do you want a copy of it too?
Yes, that'd be great. Thank you very much.
Great. All right, I will send it to you as well. So again, thank you everyone for joining us today. Rosemary, thank you so much for all the time and effort you put into this. It's very clear you know what you're talking about. And we all appreciate it very much. So again, thank you all for coming. Rosemary, thank you again. And I hope everybody has a terrific day. And thanks to those of you who messaged me. I will include you. And if you ever want to reach out to me, you can find me on the North Suburban YMCA's website. And if you have a presentation you'd like to offer, or if you want to learn more about what we're doing, let me know and we can communicate that way.
Karen, can you repeat the website again?
The website is www.ns for North Suburban YMCA.org.
Okay.
Thank
you. Thanks, Rosemary.
Thank you to all my colleagues for joining me. I really appreciate it.
Is that the YMCA where Eileen Heineman works?
I don't recognize that name, so I don't think so, because I think I know everybody who works there.
Okay.
You're the one off of Finkston, right?
That's the one at Finkston and Techney in Northbrook. Yep.
Okay.
Yep. Exactly. All right. Thanks, everybody. Take care now.
Everyone.
So long.
Thank you.
Bye.
Bye-bye.